So you're currently the president of the Milbank Memorial Fund. Previously, you were the health insurance commissioner of the state of Rhode Island. Can you tell me a little bit about how you came to be the health insurance commissioner of the state of Rhode Island and your activities in that role?
Sure. My background's in managed care. I worked for a staff model HMO in Buffalo coming out of graduate school. And then after about 7 or 8 years doing various positions there, I applied for and became the Chief Executive Officer of Neighborhood Health Plan of Rhode Island, a community health center sponsored Medicaid managed care HMO in Rhode Island. This was in the mid-90s when Medicaid managed care was just starting up and states were moving a lot of their populations into managed care. I did that job for about 8 years, and the legislature had just created this health insurance commissioner role, and I was asked by the governor to come and serve in that, and I thought it was an interesting challenge, so I took it up.
And so this role of health insurance commissioner, my understanding is that this was the first position of its kind in the nation. What is unique about this role, and why don't other states have it?
So I think actually to sort of understand the role, you have to understand why it was created. The legislature experienced the political action of a whole bunch of physicians who actually literally marched on the State House saying you have to do something about Blue Cross and Blue Shield, which at the time had about 80% of the commercial market and wasn't really doing much to keep the physicians happy. They were holding fees down because they had to build their reserves back up. And the physicians revolted, and the legislature felt like they had to react. And so what they created was this new health insurance commissioner role that took health insurance, commercial health insurance regulation out of the traditional insurance apparatus and established its own cabinet level position, gave it a few FTEs, not really very much, but actually very broad and new statutory authority. And so that was what was kind of unique about it. I think why it has been created in other states, I think those are political questions. We've had inquiries about why that is. I think there's a fair amount of resistance when you create a strong regulator role, and I would imagine that the political resistance has been pretty significant in some of the other states where they don't even have rate review, for instance. So.
Well, speaking of rate review, under your leadership, the Rhode Island has been nationally praised for its rate review process and also for other efforts to use insurance market regulation to promote payment reform. Can you talk a little bit about those initiatives?
Sure. When you're a regulator, you go back and you look at your statutory charge. What are the things I'm supposed to do? What are the things I must do? Or what are the things I can do? And what makes the position in Rhode Island unusual is that it's really given 4 statutory charges besides the normal insurance to protect the solvency of insurers. No one wants a bankrupt insurer, and to guard the interests of consumers. The Health Insurance Commission in Rhode Island is really supposed to, or is also charged with guarding the fair treatment of providers, or ensuring the fair treatment of providers, and seeing the system as a whole and directing health plans towards policies that improve the system. And as my lawyer would say, that directing the health plans, that's a shall, not a may. You are compelled to do that as the commissioner, and you have to figure out what those policies are. And there really isn't a whole lot of background in the statute to say what those policies should be or how you ought to use it. So we sort of huddled around in our office and said, how could we do this? And it turns out that we had pretty comprehensive rate review legislation on the books that wasn't used very much. It was almost like a gate that the insurers have to pass through. And now the legislature was saying, here's what you ought to look at when you're looking at the insurers' rates. You ought to look at, do they have in place policies that improve the system? So in effect, rate review was sort of the check or the inspection point that we could use for looking at what they were doing to improve the system. And actually in the first couple of years, we asked them what they were doing. Their answers were sort of all over the map. And then we started developing a process to say, well, these are the policies that we think you should be doing. Now, it wasn't just me coming up with it. We had a public input process to figure out what the priorities should be. But in a small state like Rhode Island, with very few insurers, that's a kind of a state role. I think in a larger state with a much different, bigger insurance market, you might have a different regulatory role, but that's what we had.
And so how effective do you think that those initiatives were, the rate review initiative?
So the rate review consisted of two parts. One, looking at the rates and kind of tearing them apart and figuring out why they said their rates were going up. And that actually was we used it as a public education process. We used it to say to business people, look, if you don't want your rates to go up 8%, you cannot also say, you got to pay my doctors more, or you got to pay my hospitals more. And I had legislative testimony where people would come and say, how come my rates are so expensive, and how come my doctors don't get paid more? And I would sort of say, you have to square that. So there's a public, I think one point of rate review is a public education process. The second is, did you actually take costs out of the system? And it turns out our individual and small group rates were actually at the lower end for the region. So I wouldn't say it was the only way to go about this, but we have a highly concentrated hospital market in Rhode Island, highly concentrated insurance market, so it kind of calls for regulatory solutions. And then the last piece is sort of what we articulate as priorities for the insurers. And we really focused on two things. Hospital payment reform, because we had hospitals with very strong market positions that really weren't too interested in changing quickly. And more importantly, actually primary care payment reform. The evidence is pretty clear that you need good, strong primary care. And in the U.S., we spend 6% of our total medical spend on primary care. So we actually said to the insurers, you have to move that 6% of your spend to 11% and do it in non-fee-for-service ways. And that's where we really had, I think, a lot of interesting reaction. The insurers didn't think we were serious at first, and then they realized that they could use us as the heavy when they had to say no to other people. So they literally would say no to specialists, yes to primary care, and then say to the specialist, if you don't like it, go talk to the state. They're the ones that told us to do it. And we're happy to do that because we need, for a high-performing health system, we need stronger primary care more than we need better paid dermatologists or something. So.
And what impacts do you think that process has had on the system in Rhode Island?
So I can't say, to be honest, that our rates of increase are any slower than other places. I think we were pleased to find out, as I said, that our commercial health insurance rates, once we got the exchange up and running, were actually comparable to or lower than in the region. I think we have a much more innovative primary care and energized primary care leadership, which is really important for some of these changes. You've got to have a citizenry that believes that this sort of thing can happen. And the hospitals, I think we had kind of a signal effect, but as I understand it, the hospitals in Rhode Island are more serious about payment reform. And that's because of a constellation of things. The Affordable Care Act is making them pay a lot more attention to it. So I think we have more of the positions or things in place, and we have a much more engaged conversation than what we did before.
Speaking of the Affordable Care Act, your office was also in charge, as I understand, of sort of rolling out the Affordable Care Act in terms of the exchanges and other aspects of it. Can you talk a little bit about that experience? Yeah,
well, in case anybody from Rhode Island watches, I wouldn't overstate the position to say that we were in charge of rolling it out. I think early on, we got the first two rounds of federal grants. So there was an exchange planning grant and an exchange development grant. And we served as the lead agency for the state to obtain that money. In the course of the planning grant, there was a determination made that we were going to have a state-based exchange, that we were going to have an integrated enrollment and eligibility system with Medicaid. And so during the planning process, there really was a pretty vigorous interagency planning process, actually led by our Lieutenant Governor. When Governor Chafee, the current governor of Rhode Island, came in, his second executive order was to establish a health policy, an interagency health policy group led by an independently elected lieutenant governor. It was pretty unusual. He just sort of said, Lieutenant Governor Roberts had a lot of experience with it. He said, here, you go run it. You have expertise here. I'm giving you the authority. And so we had this very healthy interagency planning process, and it's our exchange. We were the first to get a full exchange implementation grant. We got the exchange up and running. It's really been, and we expanded our Medicaid. So in Rhode Island, it's been quite successful with it. But I would hesitate to say that our office ran the whole thing.
What were some of the challenges, though, in getting the exchanges and other parts of the Affordable Care Act up and running?
My goodness, you've got to go through a policy decision about, are you going to do a state-based exchange or a federal exchange? And in Rhode Island, with a small state, that's particularly challenging. Then you've got to figure out your stance relative to Medicaid. And I think one of the most important challenges we faced was, were we really going to have a single point of entry for Rhode Islanders, so that when they wanted to find out were they eligible, on what could they get under the Affordable Care Act, could we really design a single process supported by a single IT system, so they could go in one place and determine, are they eligible for exchange, for Medicaid under the Right Care program, what their options are, and just working behind the scenes with procuring a vendor, figuring out roles and responsibilities with labor unions, because there's a lot of union positions that are involved. That ends up being very challenging. And then we had to pick vendors for these things, and we had differences of opinion. And as we've learned in other states, who you selected as a vendor made a big difference in terms of how successful you were with the implementation.
So turning now towards your new position as president of the Milbank Memorial Fund, what kinds of activities is Milbank doing around the implementation of the Affordable Care Act?
So our the fund's mission is to improve population health by connecting leaders and decision makers with the best evidence and experience. We work primarily with states; those are leaders and decision makers we're most interested in. But we have to recognize that, particularly with the Affordable Care Act, I mean, it's the most significant piece of social legislation in the last 50 years. There's a lot of entities that want to work with the states. So where can we make a particular difference? And we're actually tending to stay away from the questions of insurance access. Some of our foundations, the federal government itself, has done a great job sort of getting that up to speed. And we're trying to help the states think about, okay, if you do insurance expansion, what are the problems you're still going to have to worry about? How are you going to do multi-payer payment reform? How are you going to think about claims analysis and claims aggregation? So we're working more on the delivery system side, and then we're trying to help state health policymakers again think about those social determinants of health. The most important things we can do to increase our lifespan have nothing to do with the medical care that we get. It's all about diet and exercise and nutrition and making sure our kids get through high school without getting pregnant. And policymakers know that, but in the meantime, Medicaid keeps eating up all their budget. And how do you kind of help them wrestle with that reality that they have? So we're working on, again, multi-payer primary care practice projects. We're working on helping states measure the total costs of their care. We just got pulled into, sort of recently, high-cost drugs, because Medicaid directors they're pulling their hair out over this hepatitis C drug and how they can afford paying for it. So those are the kinds of issues we get into.
Well, I know that you say the Milbank's not working so much on access, but I did notice that you had done some work around the so-called private option that certain states that have sort of rejected the Medicaid expansion, but are agreeing to it on the terms that the subsidies be used to go towards the purchase of private insurance for people eligible for Medicaid. I'm just wondering what your thoughts are on that as a tool to expand access.
So we've learned a little bit about that from our colleagues in Arkansas. That convening that you talked about actually was because a Health and Human Services secretary called up and says, we'd like to learn more about this, but in a pretty safe space, just where we can ask questions and not have a whole lot of press there. We're not sure what we want to do. We just want to learn about it. And we pride ourselves on our ability to kind of convene people safely and just let them ask questions of one another without necessarily an expert in the way. So I was in that session just listening like everybody else. I think it's the logic around it and the political logic is really compelling in certain states. There is a great resistance in certain states to the idea of creating more entitlements with separate benefits for different classes of people. And the leaders in Arkansas of all different political stripes said, you're right, we're going to preserve Medicaid for extremely high needs people, but for the healthy low income people, they're going to buy the same insurance as everybody else. They might get some more subsidies to help them purchase it, but in terms of benefits, the way they access it, it's going to look like everybody else's health insurance. And that's as powerful as a political argument. I think then, if you're interested in those populations, there's an interesting debate about do populations of lower socioeconomic status actually need more benefits? I ran a Medicaid managed care plan. We did bus passes to help people get to their medical appointments. You can have a good argument about whether or not our benefits ought to include those sorts of enablers. To say that a core medical benefit covers exactly the same stuff, and if you're lower income, we'll just help you buy it, that's a pretty compelling political argument, and through some very good leadership in Arkansas, they've been able to make it stick. It's come under pretty intense scrutiny.
Great. Well, those were all the questions that I had for you. Thank you so much for joining us.
Sure. Thank you very much for having me.